Question 1. What is the recommended compression depth for adults during high-quality CPR? A. At least 1 inch 2.5 centimeters. B. At least 1.5 inches 3.8 centimeters. C. At least 2 inches 5 centimeters. D. At least 2.5 inches 6.4 centimeters. Answer, C. At least 2 inches 5 centimeters. This question tests your knowledge of high-quality CPR components, specifically the correct compression depth for adults. The key phrase, high-quality CPR, emphasizes adherence to AHA guidelines. For adults, chest compressions should be at least 2 inches 5 centimeters deep but no more than 2.4 inches 6 centimeters to ensure adequate blood flow while avoiding excessive force. Imagine you're trying to push blood out of the heart with each compression. Insufficient depth won't be effective. Here's a helpful tip. Think of 2 inches as the minimum standard for effective adult chest compressions. Question 2. A patient presents with a regular, narrow complex tachycardia at a rate of 180 bpm. Vagal maneuvers have been attempted without success. The patient is awake, alert, and normotensive. What is the most appropriate initial pharmacological intervention? A. Adenosine 6 mg rapid 4 push. B. Amiodarone 150 mg 4 over 10 minutes. C. Diltiazem 15 to 20 mg 4 over 2 minutes. D. Synchronized cardioversion 50J. Answer, A. Adenosine 6 mg rapid 4 push. This scenario describes a stable narrow complex tachycardia, and the question asks for the initial pharmacological intervention after vagal maneuvers fail. The key clues are regular, narrow complex tachycardia and stable patient presentation, awake, alert, normotensive, which points to adenosine as the first-line drug for organized narrow complex rhythms that are regular. Adenosine temporarily blocks AV nodal conduction, often terminating reentrant supraventricular tachycardias, SVT, and allowing rhythm identification. For example, if you see an ECG showing a rapid, regular, narrow rhythm, and the patient is stable, adenosine is your go-to. Remember, adenosine is for stable, regular, narrow complex tachycardias. Question 3. During an adult cardiac arrest, what is the recommended dose of epinephrine for intravenous/intraosseous, for/IO, administration? A. 0.1 mg every 3 to 5 minutes. B. 0.5 mg every 3 to 5 minutes. C. 1 mg every 3 to 5 minutes. D. 2 mg every 3 to 5 minutes. Answer, C. 1 mg every 3 to 5 minutes. This question assesses your knowledge of pharmacology during adult cardiac arrest. The critical information is adult cardiac arrest and the specific drug, epinephrine, for 4/IO routes. Epinephrine is a vasopressor that causes vasoconstriction, increasing myocardial and cerebral blood flow during CPR. The standard dose is 1 mg administered every 3 to 5 minutes during resuscitation efforts for both shockable and non-shockable rhythms. Think of it as a consistent boost to circulation throughout the arrest event. Remember, 1 mg every 3 to 5 minutes is the standard dose for epinephrine in adult cardiac arrest. Question 4. A patient in cardiac arrest is found to be in pulseless ventricular tachycardia, private. After the first defibrillation, what is the next intervention you should immediately perform? A. Administer 1 mg epinephrine 4/IO. B. Administer 300 mg amiodarone 4/IO. C. Check for a pulse. D. Resume high-quality chest compressions. Answer, D. resume high-quality chest compressions. This question tests your understanding of the cardiac arrest algorithm for shockable rhythms. The key event is after the first defibrillation for pulseless ventricular tachycardia. The immediate action after any defibrillation attempt, regardless of whether the shock was successful, is to resume high-quality chest compressions without delay. This minimizes the hands-off time, ensuring continuous blood flow to the vital organs. For instance, if you shock a patient, don't pause to check a pulse or give drugs. Immediately start compressions again for 2 minutes. Always remember, shock, then immediately resume CPR. Question 5. Which of the following is considered a non-shockable rhythm in cardiac arrest? A. Ventricular fibrillation, VF. B. Pulseless ventricular tachycardia, private. C. Asystole. D. Monomorphic ventricular tachycardia with a pulse. Answer: C. Asystole. This question focuses on identifying non-shockable rhythms within the cardiac arrest algorithm. The concept tested is the differentiation between rhythms that respond to defibrillation and those that do not. Ventricular fibrillation, VF, and pulseless ventricular tachycardia, private, are organized electrical activity that can be interrupted by a shock, while asystole, a flat line on the ECG, indicates a complete absence of electrical activity, making defibrillation ineffective. Imagine trying to restart a completely dead battery with a jolt. It won't work. Remember, if there's no electrical activity, you can't shock it. Question 6. What is the primary reason for administering atropine in bradycardia? A. To decrease myocardial oxygen demand. B. To block the effects of the vagus nerve. C. To increase peripheral vascular resistance. D. To convert atrial fibrillation to sinus rhythm. Answer: B. To block the effects of the vagus nerve. This question tests your pharmacological knowledge regarding atropine's mechanism of action in bradycardia. The key context is bradycardia, implying a slow heart rate. Atropine is an anticholinergic drug that works by blocking the vagus nerves, parasympathetic nervous system, action on the heart, which normally slows the heart rate. By blocking these effects, atropine allows the heart's natural pacemaker to speed up, increasing the heart rate. For example, if a patient's heart rate is dangerously slow due to excessive vagal tone, atropine helps to remove that braking effect. Here's an easy way to remember it: atropine is like taking your foot off the brake pedal of the heart. Question 7. A patient presents with acute shortness of breath, hypotension, and jugular venous distension, with clear lung sounds. What potential reversible cause, HNT, should be strongly considered? A. Hypovolemia. B. Tamponade, cardiac. C. Tension pneumothorax. D. Hypoxia. Answer: B. Tamponade, cardiac. This question requires you to identify a specific reversible cause from the HS and TS based on a classic triad of symptoms. The keywords are shortness of breath, hypotension, jugular venous distension, and crucially, clear lung sounds. This combination strongly suggests cardiac tamponade, where fluid around the heart prevents it from filling properly, leading to obstructive shock. A tension pneumothorax also causes JVD and hypotension but typically presents with diminished or absent breath sounds on the affected side, and hypovolemia usually doesn't cause JVD. Imagine the heart being squeezed by fluid, preventing it from effectively pumping blood. This specific set of signs is a strong clue for tamponade. Question 8. What is the recommended initial energy dose for synchronized cardioversion of unstable monomorphic ventricular tachycardia? A. 50 to 100 J. B. 120 to 200 J. C. 200J. D. 360J. Answer A. 50 to 100J. This question tests your knowledge of synchronized cardioversion energy levels for specific arrhythmias. The key phrase, unstable monomorphic ventricular tachycardia, specifies the rhythm and the patient's condition. For unstable monomorphic VT, the initial energy dose for synchronized cardioversion is typically lower, starting at 100J, or 50 to 100J for monomorphic VT that is regular, as higher energies are often not needed and could potentially cause more myocardial stunning. You are trying to reset the electrical activity, not necessarily ablate it. For example, if a patient with a regular, wide complex rhythm becomes hypotensive, you'd prepare for synchronized cardioversion, starting at this lower energy. Remember, for monomorphic VT, think lower energy for the initial shock. Question 9. In the post-cardiac arrest care algorithm, what is the target temperature range for targeted temperature management, TTM, in patients who remain comatose? A. 32 to 36 degrees Celsius. B. 34 to 38 degrees Celsius. C. 36 to 40 degrees Celsius. D. 30 to 34 degrees Celsius. Answer A. 32 to 36 degrees Celsius. This question assesses your knowledge of post-cardiac arrest care, specifically targeted temperature management, TTM. The key context is post-cardiac arrest care and comatose patients, indicating the need for neuroprotective strategies. TTM involves cooling the patient's core body temperature to a range of 32 degrees Celsius to 36 degrees Celsius for at least 24 hours to improve neurological outcomes by reducing metabolic demand and preventing secondary brain injury. It's like putting the brain into a protective, slow-motion state after a major insult. Think of 32 to 36 degrees Celsius as the sweet spot for preserving brain function after a cardiac arrest. Question 10. A patient presents with chest pain suggestive of an acute coronary syndrome, ACS. Which of the following is the most important initial diagnostic test to perform within 10 minutes of arrival? A. Troponin level. B. Chest X-ray. C. 12-lead ECG. D. Complete blood count. Answer C. 12-lead ECG. This question targets the crucial initial steps in managing suspected acute coronary syndrome, ACS. The keywords chest pain suggestive of ACS and most important initial diagnostic test within 10 minutes highlight the urgency and priority of early diagnosis. A 12-lead ECG is paramount as it rapidly identifies ST segment elevation myocardial infarction, STEMI, which requires immediate reperfusion therapy. Other tests like troponin levels take longer for results, and a chest X-ray or CBC are less critical for initial ACS diagnosis and management decisions. Always remember, in suspected ACS, a 12-lead ECG is your priority within the first 10 minutes. Question 11. What is the recommended maximum duration for an interruption in chest compressions during CPR? A. 5 seconds. B. 10 seconds. C. 15 seconds. D. 20 seconds. Answer B. 10 seconds. This question assesses a crucial aspect of high-quality CPR, minimizing interruptions. The concept is about ensuring continuous blood flow during resuscitation. Maximum duration for an interruption is the key phrase, emphasizing the strict limit. High-quality CPR emphasizes minimizing hands-off time to maintain perfusion pressure, and any interruption should ideally be kept under 10 seconds. For example, when you pause for a rhythm analysis or shock, be ready to resume compressions immediately after. Keep in mind that continuous, uninterrupted chest compressions are vital for patient outcomes. Question 12. You are managing a patient with symptomatic bradycardia unresponsive to atropine. The patient is hypotensive and has altered mental status. What is the most appropriate next intervention? A. Transcutaneous pacing. B. Dopamine infusion. C. Transvenous pacing. D. Observe closely and reassess. Answer: A. Transcutaneous pacing. This question focuses on the management of unstable bradycardia. The critical clues are symptomatic bradycardia, unresponsive to atropine, and signs of instability like hypotension and altered mental status. When atropine fails for symptomatic bradycardia, transcutaneous pacing, TCP, is the next immediate step to rapidly increase the heart rate and improve perfusion. Dopamine or epinephrine infusions are considered alternatives or adjunctive therapies but usually follow TCP or are used if TCP is ineffective. Transvenous pacing is more invasive and takes longer. Think of TCP as a quick external fix to get the heart rate up when the patient is unstable. Question 13. Which of the following is the most reliable method for confirming and continuously monitoring endotracheal tube placement? A. Bilateral chest rise. B. Auscultation of breath sounds. C. End-tidal carbon dioxide, EtCO2, monitoring. D. Esophageal detector device. Answer: C. End-tidal carbon dioxide, EtCO2, monitoring. This question addresses a critical aspect of airway management, confirming and continuously monitoring endotracheal tube placement. The keywords are most reliable method and continuously monitoring. While bilateral chest rise and auscultation provide initial assessment, they are not definitive and can be misleading. End-tidal CO2, EtCO2, monitoring, specifically capnography, is considered the most reliable method because it provides a waveform confirming CO2 exhalation, indicating tracheal placement, and continuously monitors ventilation effectiveness. It's like having a real-time display of whether the tube is truly in the airway. Always rely on capnography for definitive tube confirmation. Question 14. What is the maximum recommended dose of adenosine for a single 4-push in stable narrow complex tachycardia? A. 6 mg. B. 12 mg. C. 18 mg. D. 24 mg. Answer: B. 12 mg. This question tests your knowledge of adenosine pharmacology, specifically its maximum single dose. The context is stable narrow complex tachycardia, where adenosine is a primary intervention. The initial dose of adenosine is 6 mg, and if the rhythm does not convert, a second dose of 12 mg can be given. There isn't a third dose recommended, making 12 mg the maximum for a single administration. Imagine you're giving 2 tries with increasing strength to reset the heart's rhythm. Remember, 12 mg is the highest single dose of adenosine you should give. Question 15. A patient with acute ischemic stroke symptoms arrives in the emergency department. What is the critical time window for initiating fibrinolytic therapy, e.g., alteplase, from symptom onset for eligible patients? A. Within 1 hour. B. Within 3 hours. C. Within 4.5 hours. D. Within 6 hours. Answer: C. Within 4.5 hours. This question addresses the time-sensitive nature of acute ischemic stroke management. The key information is acute ischemic stroke symptoms and critical time window for initiating fibrinolytic therapy. While the sooner the better, the current guideline for eligible patients is to initiate fibrinolytic therapy within 4.5 hours of symptom onset. This time frame is crucial because the effectiveness of clot-busting medications significantly decreases with time. It's like a race against time to save brain tissue before it's irreversibly damaged. Always remember the 4.5-hour window for alteplase in acute ischemic stroke. Question 16. What is the recommended compression to ventilation ratio for adult true rescuer CPR without an advanced airway? A. 15:2. B. 30:2. C. 30:1. D. Continuous compressions with one breath every 6 to 8 seconds. Answer: B. 30:2. This question focuses on the specific compression to ventilation ratio for adult CPR, particularly in a true rescuer scenario without an advanced airway. The keywords adult, true rescuer, and without an advanced airway are crucial distinctions. For adult true rescuer CPR without an advanced airway, the recommended ratio remains 30 compressions followed by 2 ventilations, allowing for efficient circulation and oxygenation. This ratio balances the importance of compressions with adequate breathing, unlike continuous compressions which are used with an advanced airway. Think of it as a consistent rhythm: 30 compressions, 2 breaths, 30 compressions, 2 breaths. Question 17. After intubation, what is the recommended ventilation rate for an adult in cardiac arrest? A. 8 to 10 breaths per minute. B. 10 to 12 breaths per minute. C. 12 to 15 breaths per minute. D. 15 to 20 breaths per minute. Answer: B. 10 to 12 breaths per minute. This question tests your knowledge of ventilation rates once an advanced airway is in place during adult cardiac arrest. The key phrase "after intubation" signifies the presence of an advanced airway. Once an advanced airway is secured, ventilations should be delivered at a rate of 1 breath every 5 to 6 seconds, which translates to 10 to 12 breaths per minute, without pausing chest compressions. Overventilating can be detrimental by increasing intrathoracic pressure and reducing venous return, making it less effective. Imagine delivering a breath just frequently enough to oxygenate, but not so often that it hinders blood flow. Question 18. A patient is experiencing polymorphic ventricular tachycardia, PMVT, with a normal QT interval, and is unstable. What is the most appropriate initial intervention? A. Adenosine. B. Magnesium sulfate. C. Synchronized cardioversion. D. Defibrillation, unsynchronized shock. Answer: D. Defibrillation, unsynchronized shock. This question presents a critical scenario involving an unstable polymorphic ventricular tachycardia. The keywords are polymorphic ventricular tachycardia and unstable. When PMVT is unstable, particularly if it's irregular, e.g., torsades de pointes, an immediate unsynchronized shock, defibrillation, is indicated because the R waves are not consistently present or identifiable for synchronized delivery, and delaying treatment for synchronization can be fatal. If the QT interval were prolonged, torsades de pointes, magnesium would be given in addition, but for unstable PMVT, immediate defibrillation is first. Consider it a critical, life-saving reset button for a chaotic and dangerous rhythm. Question 19. What is the primary role of a team leader during a resuscitation attempt? A. Performing chest compressions. B. Administering medications. C. Directing team members and making treatment decisions. D. Documenting the resuscitation efforts. Answer C. Directing team members and making treatment decisions. This question evaluates your understanding of effective team dynamics in a resuscitation setting. The concept is about leadership roles. The primary role of a team leader is to oversee the entire resuscitation, ensuring tasks are assigned, performed correctly, and that critical decisions are made according to ACLS algorithms. While all roles are important, the leader is the conductor of the orchestra, guiding the team. They are responsible for big-picture strategy and clear communication, rather than hands-on tasks. Think of the team leader as the person with the map for the entire rescue effort, ensuring everyone knows their path. Question 20. What is the recommended treatment for a patient with symptomatic torsades de pointes? A. Amiodarone. B. Lidocaine. C. Magnesium sulfate. D. Atropine. Answer C. Magnesium sulfate. This question tests your specific pharmacological knowledge for a particular type of polymorphic ventricular tachycardia. The keyword torsades de pointes, a specific form of polymorphic VT with a prolonged QT interval, is the crucial clue. Magnesium sulfate is the first-line treatment for torsades de pointes, regardless of the patient's magnesium level, as it helps to stabilize the myocardial cells and prevent further episodes. Other antiarrhythmics are not typically indicated as initial therapy for torsades. If you see torsades, think magnesium first, to help stabilize the heart's electrical activity. Question 21. Which intervention should be prioritized for a patient presenting with an ST segment elevation myocardial infarction, STEMI? A. Administration of sublingual nitroglycerin. B. Immediate transport to a PCI-capable facility. C. Administration of aspirin and oxygen. D. For access and blood draw for labs. Answer B. Immediate transport to a PCI-capable facility. This question assesses the critical management strategy for STEMI. The concept is about rapid reperfusion. The key information is ST segment elevation myocardial infarction, STEMI, which indicates an acute, complete blockage of a coronary artery requiring immediate restoration of blood flow. While aspirin and nitroglycerin are important initial medications, the absolute priority for a STEMI patient is rapid reperfusion, ideally via primary percutaneous coronary intervention, PCI, at a specialized facility. Time is myocardium, meaning faster treatment saves more heart muscle. For a STEMI, getting them to the cath lab is the top priority. Question 22. What is the appropriate initial action when a patient with a suspected opioid-associated life-threatening emergency is unresponsive and has agonal breathing? A. Administer naloxone immediately. B. Provide rescue breaths only. C. Start chest compressions. D. Check for a pulse for no more than 10 seconds. Answer D. Check for a pulse for no more than 10 seconds. This question tests the initial assessment steps in a suspected opioid-associated emergency, specifically regarding life-threatening signs. The critical keywords are unresponsive, agonal breathing, and suspected opioid-associated. While naloxone is the antidote, the initial priority is always to determine if the patient is in cardiac arrest. According to AHA guidelines, if an unresponsive person is not breathing normally, e.g., agonal breaths, you should check for a pulse for no more than 10 seconds. If no pulse is found, then begin chest compressions. If a pulse is present but breathing is absent or inadequate, provide rescue breaths. Always assess pulse and breathing first to guide your next intervention. Question 23. A patient in cardiac arrest has achieved return of spontaneous circulation, ROSC. What is the initial recommended target for systolic blood pressure during post-cardiac arrest care? A. Above 70 millimeters of mercury. B. Above 80 millimeters of mercury. C. Above 90 millimeters of mercury. D. Above 100 millimeters of mercury. Answer: C. Above 90 millimeters of mercury. This question addresses the immediate post-cardiac arrest care, specifically hemodynamic management. The concept is about maintaining adequate perfusion after ROSC. The critical information is return of spontaneous circulation, ROSC, and initial recommended target for systolic blood pressure. To ensure adequate cerebral and coronary perfusion after ROSC, the AHA guidelines recommend maintaining a systolic blood pressure of at least 90 millimeters of mercury or a mean arterial pressure, MAP, of at least 65 millimeters of mercury. This helps to prevent secondary injury from hypotension. Think of 90 millimeters of mercury systolic as the minimum goal to keep vital organs perfused after a cardiac arrest. Question 24. What is the recommended initial dose of intravenous push diltiazem for a patient with stable atrial fibrillation with rapid ventricular response? A. 0.25 milligrams per kilogram. B. 0.5 milligrams per kilogram. C. 1 milligrams per kilogram. D. 1.5 milligrams per kilogram. Answer: A. 0.25 milligrams per kilogram. This question assesses your pharmacological knowledge for rate control in a specific arrhythmia. The key context is stable atrial fibrillation with rapid ventricular response, indicating the need to slow the heart rate in a patient who is not acutely unstable. Diltiazem, a calcium channel blocker, is often used for rate control. The initial recommended dose is 0.25 milligrams per kilogram, administered intravenously over 2 minutes, with a second dose of 0.35 milligrams per kilogram if the initial dose is ineffective. You're aiming to gently bring the heart rate down without causing significant hypotension. Remember, 0.25 milligrams per kilogram is the standard starting dose for diltiazem in this scenario. Question 25. Which of the following conditions is not one of the HS reversible causes of cardiac arrest? A. Hypovolemia. B. Hypoxia. C. Hypothermia. D. Toxins. Answer: D. Toxins. This question tests your recall of the HS and TS mnemonic for reversible causes of cardiac arrest. The critical part is identifying which option is not one of the HS. The HS include hypovolemia, hypoxia, hydrogen ion, acidosis, hypo-/hyperkalemia, and hypothermia. Toxins, while a reversible cause, belong to the TS group. Toxins, tamponade, tension pneumothorax, thrombosis, coronary, thrombosis, pulmonary. Knowing this mnemonic helps you systematically identify potential underlying issues during a resuscitation. Just remember, toxins start with T, not H. Question 26. When should immediate synchronized cardioversion be performed for a patient experiencing tachycardia? A. When the patient is symptomatic but stable with a narrow complex tachycardia. B. When the patient is unstable with a wide complex tachycardia. C. When the patient is asymptomatic with a wide complex tachycardia. D. When vagal maneuvers have failed for a stable narrow complex tachycardia. Answer: B. When the patient is unstable with a wide complex tachycardia. This question differentiates between stable and unstable tachycardias and guides the appropriate intervention. The concept is about recognizing urgency. The critical clue is unstable, which indicates signs of shock, acute altered mental status, ischemic chest discomfort, acute heart failure, or hypotension due to the tachycardia. Regardless of the QRS width, any unstable tachycardia warrants immediate synchronized cardioversion. Waiting for drugs or other interventions when a patient is unstable can be detrimental. For example, if a patient with a wide, rapid rhythm becomes hypotensive, you should prepare for immediate cardioversion. Question 27. What is the primary purpose of defibrillation? A. To slow down a rapid heart rate. B. To convert pulseless electrical activity, PEA, to a perfusing rhythm. C. To depolarize a critical mass of myocardial cells and terminate ventricular fibrillation. D. To increase the force of myocardial contraction. Answer: C. To depolarize a critical mass of myocardial cells and terminate ventricular fibrillation. This question addresses the fundamental purpose of defibrillation. The concept is about how defibrillation works. Defibrillation delivers an unsynchronized electrical shock intended to depolarize nearly all myocardial cells simultaneously, thereby terminating chaotic electrical activity like ventricular fibrillation, VF, or pulseless ventricular tachycardia, private, and allowing the heart's natural pacemaker to restart with an organized rhythm. It's like pressing a reset button on the heart's electrical system when it's short-circuiting. Remember, defibrillation's goal is to stop chaos, VF/private, so the heart can restart normally. Question 28. What is the recommended initial dose of amiodarone for refractory ventricular fibrillation, VF, or pulseless ventricular tachycardia, private, in adult cardiac arrest? A. 150 mg 4/IO. B. 300 mg 4/IO. C. 450 mg 4/IO. D. 1 mg 4/IO. Answer: B. 300 mg 4/IO. This question tests your pharmacological knowledge of antiarrhythmics in cardiac arrest. The keywords are refractory ventricular fibrillation, VF, or pulseless ventricular tachycardia, private, which means the rhythm persists after initial defibrillation, and epinephrine. Amiodarone is an antiarrhythmic drug used to suppress ventricular arrhythmias. The initial dose for VF/private that is refractory to defibrillation and epinephrine is 300 mg 4/IO bolus. This is given to try and stabilize the electrical activity to allow for more effective defibrillation. Think of 300 mg as your first attempt to calm the heart's electrical storm. Question 29. A patient is in cardiac arrest due to suspected massive pulmonary embolism. Besides high-quality CPR, what specific intervention should be considered? A. Immediate coronary angiography. B. Administration of 4 fluids. C. Fibrinolytic therapy. D. Administration of atropine. Answer: C. Fibrinolytic therapy. This question requires you to identify the specific treatment for a reversible cause of cardiac arrest. The key information is cardiac arrest due to suspected massive pulmonary embolism. For cardiac arrest caused by a suspected massive pulmonary embolism, PE, fibrinolytic therapy, clot-busting drugs, may be considered, as it can dissolve the clot obstructing blood flow and potentially restore circulation. Other options like coronary angiography are for heart attacks, atropine is for bradycardia, and 4 fluids generally wouldn't resolve a massive PE. Imagine dissolving a large blockage in the lung's main blood vessel to restore blood flow. Question 30. During post-cardiac arrest care, what intervention is used to monitor the effectiveness of ventilation and estimate cardiac output? A. Arterial blood gas analysis. B. Central venous pressure monitoring. C. End-tidal carbon dioxide, ETCO2, monitoring. D. Pulmonary artery catheterization. Answer C. End-tidal carbon dioxide, EtCO2, monitoring. This question focuses on monitoring parameters in post-cardiac arrest care. The key is monitor effectiveness of ventilation and estimate cardiac output. While ABGs give snapshots of gas exchange, and central venous pressure and PA catheters provide hemodynamic data, continuous EtCO2 monitoring is uniquely useful for assessing ventilation effectiveness and indirectly estimating cardiac output. A sudden increase in EtCO2 during CPR often indicates ROSC, and stable EtCO2 values after ROSC can help confirm adequate ventilation and perfusion. It's a continuous, non-invasive way to gauge how well both breathing and circulation are working. Question 31. What is the most common reversible cause, HNT, of pulseless electrical activity, PEA? A. Hypoxia. B. Hypovolemia. C. Hydrogen ion acidosis. D. Hypothermia. Answer B. Hypovolemia. This question tests your knowledge of the common reversible causes for PEA. While all the HS and TS can cause PEA, most common is the crucial keyword. Hypovolemia, severe fluid loss, is the most frequent reversible cause of PEA because the heart has nothing to pump, leading to electrical activity without mechanical contraction. It's like having an engine running but no fuel to move the car. If you have a patient in PA, always consider hypovolemia as a top contender, and think about administering 4 fluids if appropriate. Question 32. A patient with acute onset chest pain and ST segment elevation in leads 2, 3, and AVF is suspected of having a STEMI. Which coronary artery is most likely occluded? A. Left main coronary artery. B. Left anterior descending artery. C. Circumflex artery. D. Right coronary artery. Answer D. Right coronary artery. This question tests your ability to correlate ECG findings with the affected coronary artery in a STEMI. The concept is about ECG localization of myocardial infarction. The key information is ST segment elevation in leads 2, 3, and AVF, which are the inferior leads. ST elevation in these leads strongly suggests an inferior wall myocardial infarction, which is most commonly caused by occlusion of the right coronary artery, RCA. Think of these specific leads as looking at the bottom portion of the heart, which is primarily supplied by the RCA. Question 33. When performing CPR, what is the recommended compression rate for adults? A. 60 to 80 compressions per minute. B. 80 to 100 compressions per minute. C. 100 to 120 compressions per minute. D. 120 to 140 compressions per minute. Answer C. 100 to 120 compressions per minute. This question assesses your knowledge of the fundamental components of high-quality CPR. The concept is about maintaining effective blood circulation. The recommended compression rate for adults is a critical guideline. To ensure adequate blood flow, chest compressions should be delivered at a rate of 100 to 120 compressions per minute. This rate is fast enough to maintain perfusion without causing rescuer fatigue too quickly. A helpful way to remember this is to compress to the beat of a song like "Stayin' Alive" by the Bee Gees. Question 34. What is the recommended method to open the airway for an unresponsive medical patient with no suspected cervical spine injury? A. Jaw thrust maneuver. B. Head tilt chin lift maneuver. C. Oropharyngeal airway insertion. D. Nasopharyngeal airway insertion. Answer B. Head tilt chin lift maneuver. This question tests your knowledge of basic airway management techniques. The keywords are unresponsive medical patient and no suspected cervical spine injury. In this scenario, the head tilt chin lift maneuver is the preferred method to open the airway as it is simple, effective, and lifts the tongue off the posterior pharynx. The jaw thrust maneuver is reserved for suspected spine injury. Airway adjuncts like OPA or NPA are inserted after the airway is opened to help maintain patency. This is the first and most basic step to ensure air can get in and out. Question 35. For a patient experiencing a symptomatic bradycardia, after administering atropine, what is the next drug of choice if the patient remains unresponsive and unstable? A. Adenosine. B. Dopamine. C. Lidocaine. D. Amiodarone. Answer B. Dopamine. This question assesses your knowledge of the bradycardia algorithm's drug sequence. The key context is symptomatic bradycardia, unresponsive to atropine, and unstable. If atropine fails to improve unstable bradycardia and transcutaneous pacing is unavailable or ineffective, dopamine or epinephrine infusions are recommended as second-line pharmacological agents to increase heart rate and blood pressure. Dopamine works by stimulating adrenergic receptors to increase heart rate and myocardial contractility. Think of dopamine as a backup vasopressor to support circulation when atropine isn't enough. Question 36. Which of the following is an absolute contraindication to fibrinolytic therapy in acute ischemic stroke? A. History of well-controlled hypertension. B. Minor or rapidly improving stroke symptoms. C. Prior intracranial hemorrhage. D. Current anticoagulant use without elevated INR. Answer C. Prior intracranial hemorrhage. This question tests your understanding of contraindications for fibrinolytic therapy in stroke, emphasizing patient safety. The concept is about recognizing high-risk scenarios. The keyword absolute contraindication signifies a condition that makes the therapy unequivocally unsafe. A prior intracranial hemorrhage, ICH, is an absolute contraindication because giving a clot-busting drug would significantly increase the risk of another, potentially fatal, brain bleed. Other options might be relative contraindications or not contraindications at all. This is a critical safety point to remember before administering potent thrombolytic medications. Question 37. What is the recommended minimum frequency for rotating compressors during CPR? A. Every 1 minute. B. Every 2 minutes. C. Every 3 minutes. D. Every 5 minutes. Answer B. Every 2 minutes. This question focuses on a practical aspect of high-quality CPR to minimize rescuer fatigue. The concept is about maintaining effective chest compressions. The key phrase, minimum frequency for rotating compressors, highlights the need for regular rotation. To prevent rescuer fatigue and ensure high-quality compressions are maintained, compressors should be rotated every 2 minutes, or approximately every 5 cycles of 30:2 compressions and ventilations. Switching before fatigue sets in helps maintain depth and rate. Think of it as a scheduled tag team effort to keep the quality of compressions high. Question 38. After ROSC, what is the recommended immediate intervention for a patient who suffered a STEMI prior to cardiac arrest and is still comatose? A. Routine telemetry monitoring. B. Immediate coronary angiography. C. Aggressive hyperventilation. D. placement of a nasogastric tube. Answer B. Immediate coronary angiography. This question connects post-cardiac arrest care with the management of a specific underlying cause. The crucial keywords are after ROSC, STEMI prior to cardiac arrest, and comatose. If a patient achieves ROSC and the cause of cardiac arrest was suspected or confirmed STEMI, immediate coronary angiography with PCI is recommended to restore blood flow to the heart and improve outcomes. This intervention takes precedence even over some aspects of neurological care in the initial hours. It's like finding and fixing the root problem that caused the whole event. Question 39. What is the most common cause of sudden cardiac arrest in adults? A. Stroke. B. Respiratory failure. C. Acute myocardial infarction. D. Drug overdose. Answer C. Acute myocardial infarction. This question tests your understanding of the epidemiology of sudden cardiac arrest. The concept is about the most frequent underlying etiology. The keyword most common cause is the key to identifying the primary driver. In adults, the vast majority of sudden cardiac arrests are due to a cardiac cause, most frequently an acute myocardial infarction, heart attack, leading to ventricular fibrillation or pulseless ventricular tachycardia. While other conditions can cause arrest, heart attacks are the leading cause in adults. Question 40. During assessment of a conscious patient with chest pain, what is the primary goal of initial medical therapy? A. To administer diuretics for fluid overload. B. To reduce myocardial oxygen demand and improve myocardial oxygen supply. C. To aggressively lower blood pressure to prevent stroke. D. To administer antibiotics to prevent infection. Answer B. To reduce myocardial oxygen demand and improve myocardial oxygen supply. This question focuses on the immediate management goals for a conscious patient experiencing chest pain, likely due to an acute coronary syndrome. The concept is about addressing the imbalance between supply and demand. The primary goal of initial medical therapy, e.g., oxygen, nitroglycerin, aspirin, morphine, for chest pain is to reduce the heart's workload, oxygen demand, and/or increase blood flow to the heart muscle, oxygen supply. This helps to relieve pain and limit damage to the heart. It's like giving the struggling heart a break and more oxygen. Question 41. If a patient experiences a cardiac arrest due to hypothermia, what is a key consideration regarding resuscitation efforts? A. Resuscitation efforts should be immediately terminated. B. Defibrillation attempts should be withheld until core temperature normalizes. C. Continue resuscitation until the patient is warmed to at least 30 degrees Celsius. D. Epinephrine doses should be doubled. Answer C. Continue resuscitation until the patient is warmed to at least 30 degrees Celsius. This question addresses a specific reversible cause of cardiac arrest and its management implications. The keyword hypothermia is the critical clue. For patients in cardiac arrest due to hypothermia, resuscitation efforts should continue, and the patient should be actively warmed, as no one is dead until warm and dead. Defibrillation can be attempted, though it may be less effective in profoundly hypothermic states. Continue CPR and warming efforts until the core temperature reaches at least 30 degrees Celsius before considering termination of efforts, as some patients can have remarkable recoveries. Question 42. What is the primary drug used to treat symptomatic bradycardia that is unresponsive to vagal maneuvers and has signs of instability? A. Adenosine. B. Atropine. C. Epinephrine infusion. D. Lidocaine. Answer B. Atropine. This question focuses on the initial pharmacological intervention for symptomatic bradycardia. The keywords are symptomatic bradycardia, unresponsive to vagal maneuvers, and signs of instability. Atropine is the first-line medication recommended for symptomatic bradycardia because it blocks the vagal nerve's inhibitory effect on the heart, allowing the heart rate to increase. If atropine fails, pacing or other vasopressor infusions are considered. Think of atropine as the initial pharmacological gas pedal for a slow, struggling heart. Question 43. What is the correct procedure for administering adenosine? A. Administer slowly over 2 minutes, followed by a 10 ml saline flush. B. Administer rapidly as in 4 push, followed by a rapid 20 ml saline flush. C. Administer rapidly as in 4 push, followed by a slow 5 ml saline flush. D. Administer as an intramuscular injection. Answer B. Administer rapidly as in 4 push, followed by a rapid 20 ml saline flush. This question tests the precise technique for administering adenosine, which is crucial for its effectiveness. The concept is about proper drug delivery. Adenosine has an extremely short half-life, seconds, so it must be administered as a rapid 4 push, over 1 to 2 seconds, through the port closest to the patient, immediately followed by a rapid 20 ml saline flush to ensure the drug reaches the heart before it's metabolized. Administering it too slowly or without a rapid flush will render it ineffective. Imagine pushing the drug so fast that it literally hits the heart before it degrades. Question 44. What is the recommended duration for administration of rescue breaths in a patient with a pulse but absent/agonal breathing? A. 1 breath every 2 to 3 seconds. B. 1 breath every 4 to 5 seconds. C. 1 breath every 5 to 6 seconds. D. 1 breath every 8 to 10 seconds. Answer C. 1 breath every 5 to 6 seconds. This question assesses your knowledge of rescue breathing for a patient who has a pulse but isn't breathing effectively. The keywords are patient with a pulse and absent/agonal breathing. In this scenario, the goal is to provide adequate oxygenation without causing hyperventilation. The recommended rate is 1 breath every 5 to 6 seconds, which equates to 10 to 12 breaths per minute. Overventilation can be harmful, causing gastric inflation and reducing venous return. Think of it as a slow, steady breathing pattern to support the patient's oxygen needs. Question 45. What is the primary risk associated with administering nitroglycerin to a patient with a suspected acute coronary syndrome, ACS? A. Hypertension. B. Severe bradycardia. C. Significant hypotension. D. Hyperglycemia. Answer C. Significant hypotension. This question tests your understanding of the potential side effects of nitroglycerin, especially in the context of ACS. The concept is about patient safety and drug precautions. The keyword primary risk directs you to the most concerning adverse effect. Nitroglycerin is a potent vasodilator, and its primary risk is causing significant hypotension, particularly if the patient has taken phosphodiesterase inhibitors, like Viagra or Cialis, recently or has right ventricular infarction, where they are preload dependent. Always check blood pressure and for phosphodiesterase inhibitor use before administering nitroglycerin. Question 46. What is the most appropriate action when a patient in cardiac arrest has an advanced airway in place and continuous capnography shows a sudden, sustained increase in EtCO2? A. Administer atropine. B. check for a pulse. C. Continue chest compressions. D. Discontinue CPR. Answer B. Check for a pulse. This question assesses your ability to interpret capnography findings during cardiac arrest and guide resuscitation efforts. The key phrase, sudden, sustained increase in EtCO2 in a patient with an advanced airway during cardiac arrest, is a strong indicator of return of spontaneous circulation, ROSC. When this occurs, it suggests that cardiac output has significantly improved, delivering CO2 to the lungs. The immediate next action is to check for a pulse to confirm ROSC, as you don't want to continue compressions on a beating heart. This is a critical sign that your efforts may have paid off. Question 47. What is the recommended initial dose of synchronized cardioversion for unstable atrial fibrillation? A. 50 to 100 J. B. 120 to 200 J monophasic, or 120 to 200 J biphasic. C. 200 J monophasic, or 100 J biphasic. D. 360 J monophasic, or 200 J biphasic. Answer B. 120 to 200 J monophasic, or 120 to 200 J biphasic. This question tests your knowledge of specific energy settings for synchronized cardioversion in a common arrhythmia. The keywords are initial dose, synchronized cardioversion, and unstable atrial fibrillation. For unstable atrial fibrillation, the recommended initial energy dose is 120 to 200 J for biphasic defibrillators or 200 J for monophasic defibrillators. If the initial shock is unsuccessful, subsequent shocks can be delivered at higher energy levels. You are trying to reset the chaotic electrical activity of the atria with enough energy to be effective, but not excessive. Question 48. A patient is unresponsive with a pulse, but not breathing. After administering rescue breaths, what drug should be considered if an opioid overdose is suspected? A. Epinephrine. B. Naloxone. C. Atropine. D. Diltiazem. Answer B. Naloxone. This question assesses your knowledge of specific pharmacological interventions for a common emergency. The key information is unresponsive with a pulse, but not breathing, and opioid overdose is suspected. In this scenario, where respiratory depression from opioids is the primary concern, naloxone is the specific antidote that reverses opioid effects, often restoring spontaneous breathing. Epinephrine is for cardiac arrest, atropine for bradycardia, and diltiazem for rapid arrhythmias. Always remember, for suspected opioid overdose with respiratory depression, naloxone is your go-to. Question 49. What is the primary purpose of performing a jaw thrust maneuver during airway management? A. To assess the patient's level of consciousness. B. To open the airway without extending the neck. C. To prevent aspiration of gastric contents. D. To facilitate insertion of an oropharyngeal airway. Answer B. To open the airway without extending the neck. This question focuses on a specific advanced basic airway maneuver. The concept is about protecting the cervical spine. The primary purpose of the jaw thrust maneuver is to open the airway by lifting the jaw forward, displacing the tongue, while minimizing neck movement. This technique is preferred when a cervical spine injury is suspected, as excessive neck extension, as in the head tilt chin lift, could worsen a spinal injury. Think of it as a safe way to open the airway when you're worried about the neck. Question 50. During cardiac arrest management, if 4 access is difficult to obtain, what is the preferred alternative route for drug administration? A. Endotracheal, ET, tube. B. Intracardiac injection. C. Intraosseous, IO, access. D. Subcutaneous injection. Answer, C. Intraosseous, IO, access. This question tests your understanding of alternative drug administration routes during cardiac arrest. The key information is for access is difficult to obtain and preferred alternative route. Intraosseous, IO, access is the preferred alternative route to for access for drug administration in cardiac arrest because it provides rapid access to the central circulation and allows for delivery of the same medications and fluids as the for route, with similar efficacy. Endotracheal administration is less preferred and requires higher doses, and intracardiac injection is generally not recommended. IO access is a reliable bridge when for access isn't immediately possible.